attend today. So I think we're good to go.
Yep, I think so.
Okay. Good afternoon, everybody, on a bright, I think it's still officially spring, but it feels like summer day. I've taken roll call. And so our first order of business is approval of the May 4th board meetings. Meeting, singular.
This is JJ. Move to approve.
Thank
I'll
you.
second. Finally, I'll second.
All in favor?
Aye.
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 Aye. Okay. Thank you. We're going to insert one thing here in the agenda. And Bill, do you have something to tell us?
Yeah, I just wanted to inform the board that at the end of this month, I will be leaving the OEBB board. I will no longer be a school board member as I lost my re-election bid by 68
Oh,
votes.
my.
So 68 votes made all the difference. So, but yeah, so this is an OSBA school board member seat. So I will open the seat back up for somebody from the School Board Association. So just wanted to say it's been a pleasure 4 years serving on the OEBB board. I really enjoyed it. I found it very interesting. I learned a lot and was really a fun time. So I want to thank everybody for allowing me to participate with y'all.
Well, Bill, thank you so much. You put a lot of effort into it, shown great curiosity, and been very active as a board member. And I, for one, really appreciate your participation.
Thanks.
Yeah.
You'll be missed.
I'd just like to say, Jeff, as well, that it was pretty impressive when Bill first got on the board and you'd see him actually make the drive to Salem and attend CIAL meetings, even though he wasn't on the committee. And I got a lot of great questions from Bill over the last few years, and just really appreciated the effort he put into everything he did for the board and OEBB members as a whole. So thank you.
Thanks.
Okay, the next order of business is election of board officers. Ali, you have to review the section of our charter.
Yes, thank you, Jeff. This is really bittersweet. We'll talk a little bit more about that in a couple minutes. But so in accordance with Section 9 of the OEBB bylaws, the election or reaffirmation of officers occurs each year. Robert Young, as vice chair, will move directly to the chair position, and that's effective at the next board meeting, which would be September. And the board will elect a new vice chair from a different stakeholder constituency. And action is requested to nominate a vice chair candidate or candidates. And Jeff, if you'd like to make the call for nominations, that would be great.
Great. Do we have any nominations for the vice chair position?
Yes, this is Reed, and I would like to nominate JJ.
JJ. And you are willing, JJ?
Sure.
Thank you. Is there a call for any other nominations? Tick tock, tick tock. Okay, time's up. Thank you. We do need to make it official though, so Ali, why don't you do a roll call vote on this one?
Okay. Robert?
Sorry. Yes. I support.
Bill?
Aye.
Bonnie?
Yes.
Susan Miller?
Aye.
Skip over JJ. Reed Scott Schwalbach.
Yes.
And Bob Stewart?
Yes.
and Tom Siltabo.
Yes.
That's everybody.
Do I get to,
Did you-
do I get to vote?
JJ
this
gets to
time?
vote.
Okay, sorry, JJ. Go ahead.
Yes.
Thank you.
And I'll vote as well, yes, even though it's not a tie.
Not a tie, but that's okay. Congratulations, JJ.
Yeah, thank you.
And I just, like to take a minute. Robert and I collaborated on a letter that we're sending to Jeff with an engraved gavel. And I'd just like to read it. We kind of wrote it from the board and staff. And dear Jeff, on behalf of the board and staff at OEB, we would like to offer a heartfelt thank you for your 4 years of devoted service as OEB board chair. Your leadership and contributions to the board are unrivaled and should be celebrated. Unfortunately, due to COVID-19, it will have to be a virtual celebration. But over your tenure as chair, the many achievements of OEB are in large part due to your dedication, hard work, and commitment to all OEB members. This includes strategies for advancing the coordinated care model, improving member experience via member advocacy programs, and the most critical work of containing costs while improving access to care, all while supposedly being retired. Your continued participation on the board and CIO is valued, and we hope your presence will continue to be in the long term. Sincerely, Robert and Ali. And I can just say, in the 3 years I've been the director, that Jeff has put in more time really than anyone can imagine. He really has, and just been a real driving force behind a lot of really good things that have gone on in OEB and meeting, some of the imperatives given to us from the legislature, the pandemic, just always finding time in his retirement schedule and the motivation to really make things happen. So I just want to say thank you, Jeff.
Thank you, Ollie. Well, it's been my pleasure. Thanks. Well, I have every confidence in Robert. So I know he'll do well, and JJ as well. They've both demonstrated commitment to the board, so I'm looking forward to being a member the next 2 years before I term out on that. Well, we can move on to the next agenda item with communications plan update and strategies of communication. And we turn that over to Jackie.
Hi, thanks for having me. Can you hear me okay?
Great.
Excellent. So I'm going to keep kind of the plans for this upcoming year a little brief. We basically went last year due to COVID, we cut back on a lot of our printing and mailing and did a lot more online communication. And as I presented last month in the survey results, that went really well. The members still got all the information they needed. And in fact, our scores went up a little bit. So we're going to stick with that this year. We ended up saving basically by keeping those same electronic communications tactics this year, we are saving about $165,000 over going back to the way we did things 2 years ago. So it seems to be a well worth the effort. So as far as the communications for the 21-22 plan year, we have on our website in April, when the board made the plan decisions, then we got the updated rates and plan designs on the website early May. And we have a new link on our home site, or the homepage of our website, that points people right to that. If you click on that and open it up, it gives you quick links to the rates and plan designs, as well as insurance committee information, where we have on-demand video presentations from all the carriers, including an OEB overview and copies of the slides and handouts. And we held a couple webinars. Those both went really well. And the recordings to the webinars are online. So all that stuff is on demand and people are getting their plan choices in for the next year. Next slide. We've done this every year for quite a while and it's worked out well. This is kind of a resource for our entities where online we have our whole schedule of everything that we're going to send to members so that our entity administrators can see exactly what's going out when, what the purpose of that piece is and who it's going to and how, and what date they're expected to receive it, what date we pulled the data, if that there happens to be a big gap, like for open enrollment packets, it takes a long time to assemble the packets. So it's nice for our entities to be able to see what date we pulled that data. So if they entered a new hire after that date, they know that they need to get that information to their new hire. And then we link to samples of each of those things. So currently what's up there is our previous year's communications because we don't have everything developed for the upcoming year yet, but that page will be updated as we go. Next slide. And then we always have information. We have a members section on the homepage. You can see as you scroll down, it kind of goes by what area you're looking for. So members have kind of an easy portal there. They can get started and see what's available to them. We have a quick forms link, the ways to contact us and the carriers, frequently asked questions. And that's there year round. And we also have our most popular links kind of up at the top. And then whenever we get our new enrollment guide prepared, right now we have last year's enrollment guide kind of front and center so that even new hires can reference it whenever they come along. But then when the new year booklet is ready, which should be this July, we'll replace the one that you see there with the upcoming year. And we have some vanity URLs just to make it easy for people to find things. We've got oebinfo.com is an easy way to get to our homepage. And next slide. OEBOndemand.com is an easy way for members to see all of the information that we'll be presenting at open enrollment. So again, there will be a quick link to the guide, but then there will be all of our video presentations, webinar links, the presentation slides and handouts. So it's kind of an easy way to remember that they can always go and find their open enrollment information there. Next slide. OEBenroll.com is a quick direct link to the enrollment system. So when they are ready to make their plan selections, they can get right there. And then OEBPlandocs.com is just kind of an easy way year round to be able to go and find all of the crucial information about the plans, like the handbooks and the rates and plan designs. And again, we put a link to the booklet because that seems to be the most common thing people are looking for. So we've got that on just about every page. Next slide. And then we did want to spend a little time addressing the findings of the Secretary of State audit, but I am going to kick it over to Cindy Bowman to kind of take it from here and discuss those tactics.
Hi, everyone. Can you hear me okay?
Yes.
Okay, good. Thanks. Okay, so as you know, we went through a Secretary of State audit. I've lost track of time, 2 years ago, I think it was. And they did have several recommendations for us. 3 of them were related to communication specifically. So I just wanted to kind of review what those are and kind of where we are as far as the status. So the first recommendation really related to collecting information from our members and stakeholders so that we could inform you, the board. To that end, as you know, Jackie just reviewed our customer service survey, I think it was last month. On that survey, we collect member services responses specifically, but also some benefit related, how our members feel about the benefits that they're provided. So she covered both of those. Ongoing though, we are hoping to be able to collect feedback from specific to calls that we receive from members. We do sort of have a tracking system in our current benefit system, but it's difficult to track and kind of categorize what the phone calls relate to. So we are hoping with the new benefit system hopefully implemented in a couple years that we'll be able to include more specific tracking and categorizing, so we can kind of provide a focus for what our member concerns are specifically, or hopefully what we're doing well too. We also, this is going to probably come as a surprise to our carriers because I don't think we've shared it with them yet, but we do want to design some carrier reporting specific to gathering information about benefit utilization and kind of the member experience from the carrier side of things too. So we just have started looking at that, and we'll start working with the carriers on that soon. Next slide. Our second, the second recommendation, more related to how we provide information to our customers about the work that you, the board, are doing. So they know the board works on their behalf, but we're not necessarily, I guess the Secretary of State's office thought that we were missing some opportunities to share that information with our members and stakeholders and the employers themselves. So to that end, as far as the employers and stakeholders are concerned, we already do a benefits information exchange. In fact, we have one scheduled for tomorrow. That is a virtual meeting that we provide with the OEBB entities. Primarily, it's the people in the business office and the benefit administrators. We did kind of take a hiatus last year during COVID, just the way things were. But we are resuming, again, like I said, tomorrow. And that's actually been going on for 10 years. So we are going to expand kind of the board section of that so that we can provide more specific information. A lot of times we just give them renewal information, but we want to let them know on an ongoing basis what you're working on and what the things that may be of interest to them. Next slide. So with respect to members, hopefully you're familiar with we have a new newsletter right now, and it's more specific to our wellness efforts. We are going to expand that to include more benefit topics, and in addition to just the newsletter itself, also the website content. So that will be new benefit offerings, or kind of spotlight some areas that might be of interest to members that expands beyond just wellness. We're also going to update our board webpage. Right now, pretty much what we give them is a link to stream and the documents from the actual board meetings, but we want to kind of provide some highlights of the decision-making process, what actions you've taken. Again, a lot of the information that we share is around renewals, and hopefully we'll be able to expand that section and share more information on an ongoing basis. So we're kind of working on looking at that right now.
Cindy, it looked like
slide,
JJ had a question.
Oh, okay.
Yeah, I was just curious if we looked into, I mean, sharing meeting minutes or things like that. I know we have it all posted on the site, but I don't know how easy it is to get to that. I know I rarely look as a board member for that section, but in the past when I have looked, it's a little clunky getting to it. But I know at the county level, letting our constituents know what the decision making of the executive body is an important transparency tool.
So Jackie, do you have thoughts on that specifically?
Well, I think we were talking about, maybe it's weird because just having the minutes, typically those get approved the following month and they're out there, and it's a little clinical. Like, I don't know a lot of members that would spend the time reading those.
Yeah.
But so we were talking about kind of trying to do a one-pager summary of, hey, here's what happened this month, and just make it a little more casual, but kind of just a quick overview of, this is what happened. If any of this intrigues you and you want to dig in deeper, you can go to the video and watch in more detail. But we were hoping maybe that would make it a little more engaging.
Oh, that's good. I think that's a great idea.
And I think in addition to the webpage, the newsletter that we send out that we're going to expand beyond wellness into benefits, we're going to have a board section, board topic section, I guess, of the newsletter also. So that should cover some of the information, I think, in addition to just that one page for the website.
And I think we also want to be sure to get in there, at least for the entities, if not for the members, looking ahead at the things that maybe CO is going to be exploring, or, you know, potential ideas that are up for consideration to change benefits in the future. That's a little bit of the feedback we have heard, is that people find out about it after the fact, but they're not sure what you're even considering, and they'd like to know that in advance and be able to tune in and watch those conversations and maybe submit public comment if they have any.
Thanks, Jackie. Okay, next slide. So the third recommendation that the Secretary of State's office had relates specifically to better educating our members. We know this has kind of been an area, a challenging area for us. I think the monthly newsletter is going to include some benefits education. We have looked at some benefits 101 instructional videos, so they'd have to be very generic because, as you know, the entities all have different plans and all of that, but providing, you know, a lot of times members are confused about what's my deductible, how does the copay work, what's the benefit maximum. So we're looking at being able to kind of post some benefits 101 videos on our website to help with that. We're also trying to figure out how we can develop a orientation for new hires. Again, it's a challenge because there are so many differences between the entities and bargaining units. So trying to make something that is generic enough for everybody to use is something we're going to have to really work through. I think, was that the last slide, Rose?
I think that was the end of the slides, but JJ, did you have another question?
Yeah, I just had a thought on that. I like the idea of a, you know, kindergarten level is what I like to do when I do it. I do a lot of teaching and training, and you have to just dumb it down to the lowest possible level because that's the level I personally understand. So if I can understand it, then other folks can as well. But I like the idea of a benefits 101. What I would recommend in that is a little discussion on how a primary care physician works and the role of coordination of care. And that's been probably topic number one in the last 3 to 4 years with an OEB. And to be honest, that's something that most of our members don't really understand. And I don't think we've been successful at explaining.
That's great feedback, JJ, thanks. And as far as just, I hate to use the term dumbing it down, but bringing things down to a readability, we do try to, all of our communications, we target an 8th grade reading level, and looking at not just the communications we send out, but also our web information and how we post things. And I think the videos are a perfect example of that. So we'll be sure to do that.
I just said no. It's too hot out there.
So I think that is all from me.
Looks like Reed has a question.
Yeah, it's really just more of a comment than a question. But as we think about the materials, and I agree, whoever's child said it's too hot out there. It is hot out there. I think one of the things we should be thinking about too is the scannability as people are using their phones and doing quick scans, having materials that are easily scannable. So we might think of it as simplifying it, but it's really about what's the modality the reader's using more these days, and having something that is quickly scannable so people can take away the main point or be intrigued and then want to go deeper is really important.
We did an assessment of our county website the last year, and I think 65 or 70% of users look at the website on their phone.
Those
Yeah,
both are both great points that we have on our consultant RFP, that we want whoever the winning bidder is to help us do a whole assessment of our website and make sure that we're optimizing things that way, knowing that that's how things are rolling, that we need to be able to make everything accessible on people's phones.
That's great feedback, and I just wanted to add, and I'll talk a little bit about this in the next presentation, but there's a lot of things we'd love to do, and we try to improve every year, and I think the Secretary of State audit did identify some issues, but realistically, we have one FTE, and with some consulting help, and I just wanted to say I really think Jackie does an amazing job for interacting with 240 plus entities and our members, and we actually really want board level feedback, and I'll talk a little bit in a minute about member feedback as well, but that's always welcome, no matter the time.
Okay. Any last questions for Jackie, and are we good? Okay, next order of business is the OEB Member Advisory Committee. Follow on to the last presentation. Ollie?
Yeah, thanks, Jeff. And it's just continuing on our response to the audit findings. Cindy mentioned it was 2 years ago, but it started 2 years ago, and they actually presented the findings to us about 6 months ago, which is when renewal started. So we wanted to really discuss this more in depth with the board when we had time in the agenda. So as I just mentioned, the Secretary of State identified issues in some areas of communication the staff would like to address with the board. And one of the recommendations specifically calls out the lack of a member advisory committee in OEB. The audit states that PEB's member advisory committee is underused in obtaining members' inputs, and OEB does not have an equivalent member committee to help present its over 250 employers. So the PEB member advisory is also called PMAC, was a committee that was established in collective bargaining in response to the creation of the health engagement model, which had a lot of controversy, and an OEB member advisory committee would need to be established by the board and staff. So I'm here today to discuss that with you, and to give a little bit of background. The SOS narrative continues to talk about how PMAC was created to provide feedback and advice to the board, but the board has really used them mainly in the wellness program space, and that really goes back to maybe how they're being underused and for PEB. But OEB does not have an equivalent member committee. As we mentioned, and having such a committee, the audit found that could enable more informed decision-making, improve success with initiatives, and promote better communication and relations. The OEB board is made up of key stakeholders who regularly communicate with their respective constituencies about these matters. This is our board members, you. And staff has been meeting regularly for the past year with an additional group of key stakeholders to share information and solicit member input. But what is missing, according to the audit, is the experiences of members as they obtain and pay for their health care. The audit recommendations stemming from this issue is to, quote, create a member advisory committee or an alternative method for member advice and feedback to the board. I'll skip over the considerations. Cindy talked about the benefit information exchange group that actually has been really successful over the last 10 years. You get a lot of entities participating in that. Unfortunately, you don't get all of them, but it is a great way for them to gather input. They get a lot more member input um, at the entity level than say PEB does from state agencies to their HR business managers. So skipping over considerations, on to next page. OEB staff and board leadership has been meeting with the stakeholder group comprised of representatives from OEA, OSEA, COSA, OSPA, OASBO, and OSBA seeking their input as well. This group is made up of both OEB participating entities and non-participating entities and could be expanded to include OEB members. I've talked quite a bit about this over the past 6 months. This stakeholder group has been meeting every 2 weeks to about every month, and various initiatives have been discussed, and some have reached the board already, and there'll be others coming as well. There's a lot of potential with this group, so we'll put that on hold for just a second and move to the recommendation. And I would really just conclude with the fact that it's very common for people to compare PEB and OEB, and when they see differences, they infer that there's a gap there, a gap exists. And but PEB and OEB are very different programs with very different needs. Jackie talked a little bit about, you know, we've had member educational videos for PEB, and we've had a calculator for PEB, but PEB's basically 4 or 5 medical plans that are very similar. There's 1 or 2 difference in premium shares. OEB has, I mean, everybody on the board knows hundreds of different variations out there, and creating videos is extremely challenging, and a calculator as well. And so what we'd like to do is spend some time talking with our members and stakeholders and really evaluate what would be successful for OEB. It's not necessarily what PEB has done. With that said, if the board would like to explore constructing an OEB member advisory group committee, staff will develop various options for the board's consideration that would meet the audit recommendation of obtaining member advice and feedback to the board. These options could include changes to an existing group or the creation of an entity similar to PEB's PMAC committee. These options would be brought to the board and for consideration this fall, and include resources required and costs, because it will require resources and cost. And we have a budget that is fixed, but you know, we can pursue getting additional resources. So, Tom, you have a question?
I have more of a comment. I've in the organizations that I've been in, I've seen member advisory committees, and they seem to be a lot of work and not always very effective. So I think the important thing that the board needs to hear is the recommendation around getting member feedback, and that there are multiple ways of doing that. One of the examples was, you know, as Jackie said, the survey where we ended up having, I think, 11,000 responses or something. I think that's an excellent, that is so much more powerful than getting this, trying to massage a group of 10 or 15 people on a regular basis to get them to get their opinions and feedback. The other, and there's focus groups and other approaches. I would just hope, my recommendation to the board is not to say, do we want a member advisory committee or not? It's more, we should be doing a better job of getting member comment, feedback, and what are the ways for us to do that? And again, I think there's multiple ways of doing it. That's it.
Thank you, Tom. That's great feedback.
Any other questions questions comments?
Bill. Hold on. Oh, I was waiting for my camera to turn back on. For like school board and things of that nature, from whenever we're putting out a committee, the first thing we do is put up a charter of the expectations and the expected outcomes and the feedback and the constraints of what that committee can and can't do in its makeup. So if we're going to do an advisory committee, we should first see a proposal about the charge of that committee, what its goals are, and how it's going to be made up. As in, is it going to be made up of people from different regions? Things of that nature. How are we going to get diversified input on that committee, and what is its constraints of what it can and can't do?
Yeah, you're exactly right, Bill. We're actually working on a charter. It's just about done, actually, for a joint health equity committee. Tom and Sue Ricky Smith are on with 2 HEB board members. And, like I mentioned before, it's, we implemented the innovation work group, this health equity committee, and we staff the other committees, and they don't give additional budget or resources. So sometimes it's just really, a matter of resources. And I think that's something that we can talk about when we come back to the board with some various options. And because if we had the resources that we wanted, we could probably do something pretty spectacular. But then we get brought down to reality once we submit something.
Robert, you have your hand up.
Yes, I do. So I agree with the past 2 comments, and I think it's more important to identify the need before we go straight to the solution, because I'm not sure that solution actually satisfies whatever need we have. Coming from the labor side, Reed Fields communications all the time, and we provide that feedback. If we need more of that, then there's a possibility for that. And I'm sure on the OSBA side, on the other constituent group side, we can do that. If the goal is to have more feedback, if that's the need, then I think we should look at all the possible solutions before we center in on one.
Yeah, that's great feedback as well, Robert. And like I said before, I think, it's pretty easy to line item PEB and OEB and just identify things that one or the other isn't doing and identify that as a gap, but that's not necessarily the case. And we find that time after time. And I agree. I think there's a lot more research needed to really define if there is a serious problem or one that we could address pretty easily.
So Ali, do you feel you have enough response from the board to come back at the next board meeting with some further recommendation?
I do. I can't promise it'll be the next board meeting, but this fall is what we're looking at. We're really trying to get our health equity committee up and running.
Okay.
And we'll likely need a little bit more time to really look at, we have access to other states, and we can, who have similar programs to OEB, and we can talk to them as well.
So to Robert's point, I agree that we need well-rounded feedback. I think that was Robert, or was that Tom? So for you.
Probably Tom.
So if you would, have staff continue to pursue this and add a bit more framework to possible recommendation.
I will do that. Thank you very much.
Thank you. Okay. Let's move on then to the WWW Diabetes Program Edition and the Healthy Team, Healthy You proposal. Continuation, actually. Glenn. I thought I saw your name up there earlier. Yes, Glenn, you're on mute.
Sorry.
There you go. Thank you.
Sorry about that. Yeah, we have two items. One is in regards to the Healthy Team, Healthy You renewal, and the second is in regards to the proposal for Weight Watchers for diabetes. I'll start off with the Healthy Team for Healthy You continuation. We had discussions at CIO back in April. It had been brought to us that, we have worked with Healthy Team, Healthy You since 2013. It's a program that has evolved over time to incorporate more enhanced content and features through online platform. It was recently bought by WebMD, and last year they came to us, or earlier in the year, and said that they're asking all their clients to convert to the WebMD platform. It provides more access to services. It can be more customized, much more than we're currently getting. And along with that, to go to a global pricing structure, basically a PYPM structure, whereby instead of a per participant, as we were underneath before, it would be per eligible participant. This would be done in our 21 and 22 plan year. The cost would be 0.25 per eligible participant per month, and then a $3 per eligible participant per year. All members ages 18 and older who are enrolled, basically coming out to a cost of approximately $300,000 for the 21-22 plan year. CIO reviewed this at its April meeting. They were in general agreement with the move to the WebMD. They had some concerns, though, about the global pricing structure. And especially since this would take us back to really kind of the height of when we had Healthy Team, Healthy You in regards to costs, and asked that the staff and consultants develop performance guarantees, especially around engagement. These are currently being negotiated with both the carriers and Wills Towers Watson and staff, and of course WebMD. These include a number of areas, including engagement. We had a meeting actually this morning, and we were giving a status update on this, and there was more discussion at the CL level, and they recommended that the board approve the WebMD conversion to the WebMD 1 portal, and that the global pricing structure, that the board delegate to board leadership to really give the final approval on these performance guarantees when they're finalized through staff, consultant carriers, and WebMD. Tom, Jeff, did I capture that correctly?
Yes.
So really the action before the board would be whether to go ahead with this, the conversion over to the WebMD 1 portal, and B, to the global pricing structure, with the board leadership being given the delegated or the final decision delegated to board leadership, because this will be made over the summer. So the board really wouldn't have a chance to look at it until September.
Any comments?
Jeff, do you want a motion?
I do.
Okay, I move that we approve the, as Glenn just stated, the transfer to the WebMD portal for the Healthy Team, Healthy You, and that we accept their global pricing structure given sign off by the board leadership on performance guarantees.
This Bill, I'll second.
Thank you, Bill. Is any discussion? Sorry, I got a phone call. It preempts this. So call for the vote. So let me start here with my list. Tom?
Yes.
Bob?
Yes.
Reed?
Yes.
JJ?
Yes.
Susan Miller?
Yes.
Bonnie?
Yes.
Bill?
Yes.
And Robert?
Yes.
Okay, motion carries. Is that it, Glenn?
No, we have one other item. The Weight Watchers came to us with a proposal to add their Weight Watchers for Diabetes program to the OEBB benefit. The Weight Watchers for Diabetes is a program designed to assist members within Weight Watchers who have type 2 diabetes in controlling it. It really works through the standard program and also adds personal coaching with a certified diabetes care and education specialist, personalized meal plans tailored to their lifestyle needs, and then weekly newsletter that helps members apply the workshop topics to their diabetes program. This was brought in at the April CL meeting. The CL meeting in April, we also asked the carriers to provide their both what they currently offer for type 2 diabetes and what their really recommendation would be on adding the Weight Watchers for Diabetes. Kaiser pointed out really their kind of full system really approach to diabetes, like many other conditions, as well as a lot of the support functions they give for diabetes. But they felt that, adding Weight Watchers for Diabetes could be a positive because it may reach an audience that's hard to get at, and also was really kind of non-clinical. Their program is really kind of an add-on to kind of a clinical program and focuses on nutrition and really weight therapy. MODA felt that with all the work that they're doing in regards to coordinated care and MODA 360, that this would really kind of duplicate a lot of that effort, especially around their new program, Livongo, which is a digital diabetes program. And so, though, they didn't think it was bad, they just felt that they would prefer really not to take members kind of away from a lot of the efforts and the work that's being done through MODA. The CIA reviewed this again today, and really they came up with a recommendation whereby it was offered that further study needs to be done, pretty much a side-by-side comparison of Weight Watchers for Diabetes against what the carriers offer, from the components to the modality to the outcomes, to give a more understanding about these programs and whether there is really overlap or duplication that would prevent or would kind of warrant not doing it in a sense. So the recommendation was approved by CIAO to study it over the summer, with our consultant Willis Towers Watson taking the lead, and that it would be addressed at their September meeting.
Nice summary.
I think the other thing that came out in the report was that their program is primarily targeted to type 2 diabetes, which has a close relationship with being overweight. So what actions do you need here, Glenn?
I would just say, in regards to whether the board agrees with CIAO's determination and recommendation on studying it, and then coming back in September with a recommendation.
There's a hand.
Yeah, Jeff Reed has a question or a hand up.
Yes, thank you. I fully support the idea of more study, but this is my last board meeting, so I want to make sure I get my 2 cents in, which is that if we already have people who are participating with Weight Watchers, it is to some extent a captured audience. I think the issue with diabetes and the rising cost of diabetes care that's ignored is an issue for all of us, and so there's a springboard action that we can play off of with the folks who are already engaged with Weight Watchers, then also being interested in their own diabetes care. And a question is, do we know exactly who's already enrolled in Weight Watchers, so that if we were to not go forward with this, we'd be able to very specifically do outreach to them around the Kaiser and the MODA programs?
Well, we don't know the exact name of the folks that are enrolled. I mean, OEBB staff doesn't know, but we certainly could work with Weight Watchers to see about, outreaching to these folks.
Thank you.
Reed, I think this is one of the things that we need to study over the summer, because it may be, this WW for Diabetes program may be, as you described, very closely linked just to people who are already part of the WW program in general. And at today's meeting, WW talked about being interested in collaborating with the plans around making sure that they're linked to the plan's diabetes programs also. So I think that I think that's why we need the summer to do the work.
Okay, Bill Graup.
I just also adding in my final comments here, and that I'm when I was listening to this morning, although it didn't really gel in my mind, there's a portion of the community that wants to do these kind of programs but doesn't want to participate in it in their medical office and connections on their medical records. And as far as equity and making sure that we cover groups, having a program like this where people do engage, and I do believe the correct metric that needs to be studied is how to maximize engagement in these kind of programs, accounts for those kind of people and studies them and make sure that they're included in the action that's going to happen.
Okay.
Jeff, I don't think the board needs to, unless the board wants to say definitively yes or no to WW for Diabetes. I don't think the board needs to do anything other than let CIO do its work.
I would agree. Glenn, do you need any further direction?
No, Tom's exactly right. You know, it is just, you know, just to make the board aware, they don't really need to vote on what the, CIO's doing in regards to its work, unless they feel like Tom said, they wanted to make a yes or yay or nay on Weight Watchers for Diabetes.
Okay. Well, thank you then. Moving on to our next report, reporting from the Innovation Work Group, the update there. Two major things were discussed at the last meeting. One was a report back on the RFI for Lodestar programs. In response to the RFI, there were 17 responses with information, and there were 19 responses showing interest, but no filling out additional details at that time. Quite a bit of material was covered, and the conclusion was that it would be very helpful if we got a gap analysis between what was being offered and discussed and what we currently have, because the favored approach would be, how much of this can we work out with our existing providers so that we're not overly spread out in terms of programs. And of course, we don't want to confuse our efforts on coordinated care. So they will be delivering that at the end of the summer. The Innovation Work Group has the same break as the board does over July and August. The second big issue was aligning performance guarantees, PEB and OEB. And so the health authority, the state, has been working on those and gave an interim report on those elements that would be measured and those that would be measured and subject to penalty if those standards weren't met. And so that's going forward over the summer and report back in the fall. JJ, did you have anything to add to that?
Yeah, I mean, just a couple of numbers so that people know what they are. The specific areas of measurement that will result in potential penalty if the numbers are not hit are trend rate, clinical quality, and then what we're calling administrative or operational, and basically that's customer service. So those are the three categories that they have a potential 15% penalty of their administrative fees. So, I mean, that's just as a way to hold folks accountable to quality measures. And then the areas that we kind of were digging deeper in when it comes to Lodestar, you know, we have some pros and cons were member advocacy, again, general administration, provider payments, data and quality metrics, pharmacy, and then health equity. So again, we didn't quite have enough to say, let's move forward or not, but we're marching down to see whether this is a good idea.
Any questions? Looking for raised hands here. Okay. With that, I think we're ready to move on to MOTA plan enhancements. Dr. Singh, and
we have a few people joining us today.
yeah.
Hello, my name is Erica Hedberg. Thank you for having us today. We're going to be able to go over the plan enhancements that we're making for the upcoming 2021-2022 plan year. And we're excited to be able to talk to you about these today because it's really great when you're able to add benefits for members and also increase the ways that we can help them manage their chronic conditions. So it's always good to be able to talk about enhancements like this. Next slide, Rose. Right, so before we get started on the actual enhancements, I'd just like to remind the board about MOTA 360, because all of the enhancements that we're making for the next plan year, and really all of the changes that we think about for our plans is really a part of MOTA 360. So you'll see that the enhancements that we are making really fit into, increasing member support, increasing or helping members manage their chronic conditions and providing more options for them to be able to do that. And all of that working with the member's primary care provider. And this is all powered by the shared information that we have with the member and really being able to see that 360-degree view of the member so that we can connect members to the programs that are right for them. So next slide. Right, so here's a list of the plan enhancements that we have coming up for the next plan year. And as you can see, there are quite a few. So I won't go over them right now as a list, but just want to let you know, I'll be going over some of the changes, and then we'll also have Dr. Robin Singh, our Chief Medical Officer, Bill Dwyer, our Director of Analytics, and then also Dan Toma, our Senior Manager of Behavioral Health. So next slide, Rose. Right, and our first change or first enhancement is the integration of dental into MOTA 360. So currently we have medical and pharmacy in MOTA 360, and for the next plan year, we will be integrating dental into that. So as I'm sure you guys have all heard us speak about before, and as Dr. Barrichello also touched on this morning, there's a relationship between our oral health and our physical health. And it's a bilateral relationship, meaning that our oral health impacts our overall physical health, and then our physical health also impacts our oral health. So bringing these together is important for caring for the whole person. So next slide. So there are different ways that you can integrate dental into medical, and there are things that can be done on the clinical side, and then there's also things that we can do on the carrier side. Next slide, Rose. And as you can see on the carrier side, this is where we're focusing on with MOTA 360. So it includes care coordination and information sharing, integrated disease management, and education and referrals. And on the next slide, you'll see what the member experience and what this really means for integrating dental into MOTA 360. So members who have both MOTA medical and dental with us will have all of their calls directed to our health navigator team. And then the MOTA 360 console that our health navigators use will have the dental data integrated into it so that our health navigators can help connect members to appropriate programs and also help them close gaps in care. For example, if the health navigators can see if a member has had a recent visit with a dental provider, if that's been within the last year, within the last 2 years, they can see if that member is a diabetic, and if they have had a risk assessment done by a dental provider who participates in the Health Through Oral Wellness program. And then they can also see the programs that are right for them and connect them to those programs. They'll also have enhanced digital dental tools and experience through our member dashboard. And then we'll also have care management teams that will use our integrated data for the predictive outreach and member engagement. So we'll be integrating the dental data into our outreach for engaging members into our care programs. And then our care managers will also be able to address dental and oral health issues when they're working with our members. So next slide. All right, any questions about dental integration before we move on? Right, Dr. Singh is going to talk about or get us started on our chronic kidney disease management program. Dr. Singh?
Thank you. Good afternoon, Robin Singh. Thank you for this opportunity to be able to tell you about some of the new exciting offerings that are coming up, looking at chronic kidney disease management first. So it's very common, over 10% of adults are affected and increasing in prevalence and spreading to younger ages. There are very significant health disparities that lead to chronic kidney disease. It's particularly related to diabetes, but also other causes. 25% of those who are on dialysis, sadly, pass away annually. Therefore, it is a top 10 leading cause of death, and over $100 billion per year are spent in the US. It's usually progressive and at some stage permanent. There are multiple comorbidities involved, typically, so the diabetics, but with significant cardiovascular disease. It's a multi-system disorder, so your eyes are affected, all your vessels are affected, kidney, nerves, etc. And therefore, these members have multiple needs, medical needs that can be acute in nature, decompensations requiring admission, behavioral health needs that affects employment, and often on some very specific dietary needs as well. Next slide, please. So some of the big issues in the space of how we manage these chronic kidney disease members, there's often a lack of early identification, so we don't know who has this condition. Therefore, we're not able to educate them in advance or prepare them. They often therefore crash into dialysis, really having no knowledge that they are a CKD patient, and that ends up being very expensive and complicated. The current system also drives such members to high-cost in-center dialysis that takes several hours a day, several times a week. We are going to partner with a vendor expert in this space to enhance our services. The vendor will offer basically analytics with earlier identification, predicting onset of CKD, predicting onset of those who may require dialysis, and much earlier intervention, resulting in a reduction in the progression of the disease, far more advanced care coordination, and even getting into specific disease management with nurse practitioners and a vast interdisciplinary team that can intervene, prescribe, coordinate care, and get them at the right points of delivery for that care. Next slide, please. What does that look like for the member? It's nurse practitioner led that coordinates the service from the vendor side and reaches out to all of the members' care teams, their docs and other folks, and pulls all that information together during the enrollment process, proactively schedules appointments, follows up after appointments, assures compliance with a kind of dynamic combined care plan, makes adjustments if necessary to prescriptions and to medications, gets folks to the right point of care and on the right modality of dialysis, for example. There's obviously very comprehensive educational services as well that follow. Next slide, please. And it's really about sort of meeting the members where they are. So the vendor goes as far as having specific sites of care, intervening when in the hospital setting, during transitional planning, providing phone and virtual visits, and even in the patient's home. Next slide, please. I'm going to allow Bill to give us some more details about that element where often, sadly, patients are crashing into this condition.
Yeah, hi everyone. So Bill Dwyer, Director of Analytics at MODA. And I've got 4 slides to show you. 3 of them deal with the specific ways that we feel like this program can generate a cost savings for the plan. So the first one here, the inpatient crash, like Dr. Singh just described. What you're looking at here, this chart shows the average cost for a chronic kidney disease patient based on how many months from the start of dialysis. So the 0 element there, the 0 number there on the x-axis, that's the month that the member starts dialysis. And so the blue line would be if the person is in care coordination and has been identified as somebody who is very likely to need dialysis, and we're well prepared for it, and it starts in the outpatient setting, that's what the cost is. But unfortunately, for a lot of people, like it's a surprise, that can cost on average around $80,000, that inpatient crash. So it's significant cost, not to mention just a horrible member experience to find out that way that's how you're going to start dialysis. And so if we can shift more people into the outpatient starts and just through better care management and planning, there's significant money to be saved there, in addition to improving the member's experience. Let's go to the next slide, which has a second of the 3 cost levers here. The second one here is just inpatient utilization. On the right there, that pie chart shows the inpatient, outpatient, and professional costs for a chronic kidney disease, and you can see the inpatient is quite large, $4 million. That represents, in a lot of cases, spends that we feel it could be prevented with better care coordination and management through a program like this. And so It remains to be seen how much exactly we can save, but we feel like the opportunity is significant with that $4 million in spending. And then we'll go to the last slides. We've got avoiding inpatient crash. We've got general inpatient utilization. And now another mechanism would be shifting to peritoneal and home dialysis. So there's a lot of analytical work that's been done in the industry on this topic. There's various analysis has suggested that somewhere between 10 and 20% savings for getting your dialysis at home. There's a lot of reasons for that. Just facility utilization wise, it just is cheaper to have home-based services. And there's some other benefits to members even that might improve their quality of life for getting their care at home. So we did look at the OEBB data specifically. The sample size is just too small to really draw a meaningful or reliable conclusion. What we did find is that the members getting home-based peritoneal dialysis did have a little cost advantage, but it's not statistically significant there, but certainly in line with what we expected. And so anyway, that'll be just one objective of the program, is to see where appropriate, where clinically appropriate, if we can move people into that method of treatment, it'll be better for them and better cost-wise. So let's go to the last slide I have on the chronic kidney disease is, actually I think I have 2 more, sorry, I misspoke, I had 5. So this one shows the total amount of savings we think is possible. We think that it's totally realistic to get $1 million in savings by the 3rd year of this. The savings is going to ramp up over time as we engage more and more members. In order to do this, this is going to be pretty intensive in terms of the outreach resources, because it can be hard to identify those very few members who are going to end up in dialysis among a large portion of people with chronic kidney disease. And so, so there will be program costs. However, in the vendors have a performance guarantee that's going to guarantee a positive return on investment for the program. So we feel really good about the financial structure of this and the magnitude of savings that we think we're going to get out of it. And then I think this is my last slide. So this one is just going to show how much it would end up costing. We've taken these numbers and broken them down into our best guess of the per member per month costs. And I say best guess because these are based on total OEBB membership, where we would say, total cost, for example, in year 1, 11 cents PM, based on the entire OEBB membership. But we actually don't have a great way of forecasting exactly how many chronic kidney disease members and how many members on dialysis OEBB is going to have. That's a small number, and it fluctuates pretty significantly from year to year. So what we're doing here is just giving you our best estimate of what we think the cost is, based on how many these dialysis and CKD members will have, and then we'll have to do a true up at the end of the year to make sure that our forecast for how many dialysis members, for example, there were, and make sure that we true up the forecast with the actual. But again, the savings are guaranteed to exceed the cost, so we're in pretty good shape there for showing that. Any questions on the financial aspects of this? Great. We can go to the next slide.
Thank you, Bill. I'd like to look at our musculoskeletal program. Prevention, Moda 360 navigators, wellness advisors. We have steerage with decision support and surgery support. We're building out centers of excellence there. Today, just homing in on the virtual physical therapy within the steerage and decision support element of our musculoskeletal program. Next slide, please. So the issues here to address are there is high morbidity, there's high cost, there's significant use of surgical interventions very early on for some of these conditions, lots of opiates and other painkillers, and the current system drives members over to high cost centers. We intend to partner with a vendor expert in this space to offer enhanced services in this area focused on physiotherapy. The vendor model essentially offer better diagnosis, better education, full virtual physical therapy service with coaching and evidence-based implementation, really, of evidence-based care management and care guidelines. Next slide, please. Allow Bill to take us through some of the potential cost savings in this space, which highlight how much is spent really on surgery and in the inpatient setting. And you stop mute, Bill. Thank you.
Yep. Sorry about that. Thanks, Dr. Singh. So this chart just shows how much OEB spent on claims with primary diagnosis in the musculoskeletal category. And you can see there, if I just call your attention to just a handful of these rows, the top one, the inpatient acute, and then down below there in the outpatient section, the ASC surgery and hospital surgery. You add up those together, plus some of the associated professional fees for surgery, you're talking about almost half of the cost from musculoskeletal conditions coming from surgical procedures. And so this is a pretty big area that we think we can influence with additional tools to help members through their care journey on dealing with their musculoskeletal pain.
Thank you.
So, next one.
See, this is obviously very prevalent. We see counts running into tens of thousands. There's potentially a lot of people that could benefit from this service. And yeah, the next slide, please. The virtual physical therapy is essentially a technology-based virtual physical therapist. So they get the actual therapy through the technology live, and then there are also activities that can be done later, really as much as the member would like through pre-programmed activities, along with live in-person support, in some cases offered sort of 24/7. Essentially is delivered through some hardware, like a tablet, has a screen, a camera, sensors, and of course the software that controls everything. The member wears bands over certain select areas of the body, depending on the type of exercise, and the sensor can actually track the bands. As a result of that, it can very accurately measure the exact exercise, things like range of movements and improvements, and track progress in a way that it simply was not available and is not available if this is done in person. So it has these unique technological advantages. Applies to really all conditions, every joint. Can be used both in acute settings as well as for chronic musculoskeletal pain. Can also be used around surgical intervention. Some of the goal here is to minimize the need for surgery, but actually can also be used in conjunction with surgical intervention pre and post. And lots of very accurate data can come from this in terms of range of motion, also a variety of functional outcome measuring scales. Next slide, please. Some of the potential benefits then, it's highly personalized, it's evidence-based, there's a significant degree of self-management that can be programmed. There's the convenience of timing and location. Of course, this can be done at any time and in any location versus having to schedule an appointment in person and travel to a certain setting. It can also be used much earlier and have significant ongoing intervention when face-to-face appointments just not feasible, even beyond COVID. The outcomes, we are expecting significant cost benefits, but also reductions in ED due to acute problems, reductions in overall surgery and opiate use. There should hopefully be therefore reduced levels of pain, anxiety, depression, and ideally we achieve improved productivity, improved attendance in the workplace, and reduced fatigue. Next slide, please.
Yeah, so this slide, let me just say that on the left side there, you have some examples of some claims made by vendors in this space, and they're pretty bold claims. So I will just say right off the bat, we're not guaranteeing savings in this order of magnitude. That would be a tremendous accomplishment. Savings numbers like this might be possible to what we would call the engaged population, because not every member is going to take us up on some of these services. Getting widespread engagement might be challenging because of the large number of people in the OEB population with MSK conditions, and just making sure we've got the right communication strategy to reach all those people. Just for the sake of argument, to toss out a number, I showed you in the previous slide, $60 million worth of spending. Well, 5%, if we could reduce 5% of that, that's $3 million. You know, that seems like a bold target. And I only put it out there, not to say this is what we think we're going to do, but just to give you an idea of why we're doing this, because the opportunity is so large that you know, even just a small reduction in the MSK spending would be a very big number for OEB. So anyway, with that, I'll just go to the next slide. And what we're going to do to start off, yeah, go to the next slide. There we go. What we're going to do to start off is we're not going to charge any premium impact. What we decided to do to try to make this get out of the gate as quick as possible is just to give members free access to this. So there would not be any cost share for this program. So it's a significant additional member benefit. And we're not going to charge for it. We're going to accrue the program costs as a claims expense, and then the downstream savings that we can get through either, you know, less surgery, less imaging, like fewer MRIs and CT scans, etc. That'll also accrue. And so that way OEB would just, you know, capture on a run rate basis exactly what the cost and savings from the program will be. And we feel like that's the right approach in this case because it's so uncertain as to, you know, it's really going to be hard to predict exactly, you know, what the savings are going to be in advance. And so we're going to continue to monitor the program to make sure it's effective, and we continue to fine-tune the agreement with our vendor on the quality and cost guarantees. So, so that is ongoing. Any questions on any of that?
Yeah, just starting with the September plan here.
It'll start October 1st.
October, yeah. Okay, thank you, Erica. So, you know, I'm looking at things like emergency room visits, and I'm wondering, have we done enough to drive the information around why people are going to the emergency room? Because I would guess that there's some behavior tendencies there. So people who might be open to PT might not be the same type of people who would be self-monitoring enough to reduce emergency room visits. And so this is a future piece. If we're not looking at why people are going to the emergency room, we might not be putting in place the right solution to the problem we're trying to solve.
That's a really good point, Reed.
Tom, you have a question?
Yeah, for both the chronic renal and the virtual musculoskeletal, we've heard the word vendor. Is MODA far enough along that for both of these they start at 10-1?
Yes, we are, Dr. Siltebo. We are just wrapping up contract negotiations right now and just fine tuning them, but absolutely will be implemented in time for 10-1.
Great.
Yeah, just a reminder, we're at the end of a fairly comprehensive process. We looked at dozens of vendors in this space and believe we've picked, but hopefully the best offerings nationally that are available today. We sort of not just a very comprehensive sort of scientific process, but then several folks actually testing it and trialing it in our teams to see that it works as intended. So we're quite excited about these offerings and think they're the best ones in terms of overall benefits and also potential cost reductions.
Okay, well, let's. I'm going to show you a couple of slides now on advanced imaging steerage. So let's go to the next slide. And this is a pilot program that we are doing. So we'll just call it MODA 360 Imaging Steerage Pilot Program. And the concept here, or the purpose here, is to try to give members the information that they would need to make the best decision for them on where to get advanced imaging services. Considering that, as I've showed a few times to the CL and the board, there can be a vast difference in price for the exact same service depending on where you get it. If you get it at a freestanding imaging center, for example, versus a hospital. And so here is how it works. Members can still use whatever facility they want. But when a request comes in for authorization for one of these imaging procedures, that it's mainly it's not X-rays, it's like MRIs and CT scans and the expensive ones that require prior authorization. So when we get one of these requests at an expensive site, then it triggers a member outreach where we can reach out to the member and say, hey, we noticed that you're in the pipeline to get this, this test. Did you know that because you're on a high deductible plan, this is going to cost you, probably a lot, and give them the amount and say, if you're interested in getting the same procedure somewhere else where it only costs you maybe a few $100s instead of, $1,000 or whatever, well, here's a few options for you. And then we can help the member set up the appointment if they need that. It's totally optional. And what we're focusing on right now is testing out various options, communication strategies, etc., and refining the approach before we roll it out to our larger network. So let's go to the next slide. And so kicking this off, well, this is a little outdated, so we're working on the kickoff right now. And select cases, there's about 1,600 of what we might call steerable events. That's OEB members in a typical year getting an expensive imaging procedure at a facility where there is a much cheaper option in their same region. And so just things like making sure that the imaging centers that we intend to provide the members as options, making sure they can do all the same things that the expensive place can do, testing out the scripting, etc. We're just getting we're just taking a cautious approach to make sure that everything we're telling the members about all their options is completely accurate and making sure that the communication approach is effective. And if there's no questions, go to next slide. Yep.
Thanks, Bill. And now we have Dan Thoma, who's going to talk to us about a couple of benefits we're adding for the next plan year. Dan?
Thanks, Erica. So here to talk to you about the Coordinated Specialty Programs benefit and the Disease Management Program for Pain. That's a mouthful, and there's going to be quite a few mouthfuls of acronyms and so forth as I go through this. But I'm going to start out talking about the Coordinated Specialty Programs. And what these programs are essentially, for the most part, community mental health provided programs that are a team-based program for people with more severe behavioral health conditions. So if you think about the old school version of what commercial health insurance covered for behavioral health, it was person going to the office to visit a therapist or see a psychiatrist or psychiatric nurse practitioner and get individual counseling, get medication prescription, you'd go on your way and be fine. Or you would have the higher levels of care like partial hospital program and residential and inpatient treatment that are really geared towards acute situations. And what was left out of that model was people who have higher needs and may have those higher needs for a more extended period of time. And so what we've done is we've developed a benefit to work with the existing programs that are available from providers in our community that have traditionally been funded through general fund money or through Oregon Health Plan, but have traditionally not been so available to members with people with commercial insurance. And I want to take a little bit of time to walk through how we arrived at this, because I think it's really in line with OEB's mission of healthcare transformation and changing the way that we finance and deliver services. So it goes back to a work group that then Representative Alyssa Kinney-Geyer had pulled together of multiple stakeholders to deal with the problem of people arriving at the emergency department with a behavioral health crisis and not getting the services that they need. And the hospitals were telling her, well, we can't provide the services that people need. because the insurance won't pay for them, and insurance was saying, well, what services are they getting? And the families were saying, we're not getting the services that we need. And so out of that whole process came House Bill 3090 and 3091 in the 2017 legislature, which mandated that hospitals, emergency departments provide coordinated care and comprehensive assessment, risk assessment and counseling to people who present with a behavioral health crisis, and also mandated that carriers pay for those services and pay for coordination of care. But that work group was a real eye-opener, and a theme that kept coming up over and over in that work group is that people with Oregon Health Plan as their insurance have access to an array of services that people with commercial insurance just don't have access to. And so as an outgrowth of that process, I said, well, hey, these services are typically provided by these community mental health providers, the CMHPs. And we want our people to get these services, and you won't provide them in a lot of cases because we won't pay for them. So maybe we can form a separate group to figure out how to reduce these barriers to our members accessing your services and you being able to be reimbursed for them. We made a little bit of progress in that work group. Nothing super concrete came out of that, except that towards the end of that, we identified this particular program that we wanted to focus on. And that's the program that's listed here as CATS, which stands for Crisis and Transition Services. And going back to that Kenny Geyer work group, this CATS program had been held up as the model for this is the service array that people need if they get into a behavioral health crisis and end up in the emergency department. And what the CATS program does is it'll send a clinician out to an emergency department or a crisis clinic. If called by the emergency room social worker or the crisis clinic, they'll send a clinician out to meet with the family, meet with the child, and assess for whether, if we put the right array of services around you, can you be served at a lower level of care rather than having to admit to a residential program or an inpatient program, or just be sent back out onto the streets with no help whatsoever? And so they provide intensive care coordination, lethal means counseling. They'll provide lock boxes to the family to lock up guns or knives, and intensive family therapy, psychiatry, and serve as a bridge to get that family to ongoing services that are going to help meet their ongoing needs once that crisis is stabilized. And I said, I want our members to have access to the services, to this service. They were funded through General Fund and OEBB, and the availability of those services was very spotty. So one provider, they had 6 slots for CATS, and if those 6 slots were full, the emergency room would call them up and they'd say, I'm sorry, our slots are all used up. And so that service wouldn't be available to those. So we got a bunch of different commercial insurance carriers together to work with a bunch of providers, work with the Oregon Health Authority, family advocates, peer advocates, to hammer out, how can we do this? How can we, as commercial carriers, pay for the services that you're offering, which sounds real simple until you get into the details. And how can you bill us for those services, which also sounds real simple until you get into the details, and make those services available. And so we spent about 2.5 years hammering out this model. And we came up with a model that works, and we began contracting with providers for this service. And so CATS is one example of these coordinated specialty programs, but there are a number of other programs. And what we at MODA did was we said, okay, we figured out how to do this. We can apply this lesson to a number of other services as well. And so key to having figured out how to do that, one of the real key barriers that kept coming up over and over in this work group is the member cost share. So these community mental health programs, which work mostly with general fund and with Medicaid dollars, their financial model does not include collecting a copayment from the member. And if a person's in crisis, they don't want to, sure, we'll go home with you and provide you all these great services, and can you give me your visa? That member cost share was a key barrier. So we developed this benefit to have no member cost share, really as a structural incentive for the providers to work with us and an incentive for the members to make use of these services. And that also then makes this benefit really match what people with Oregon Health Plan or their coverage through the coordinated care organizations, the array of services that are available to those folks. Next slide, please. So in some more detail, what are these services defined as coordinated specialty programs? And we list this out in the handbook, so it's very clear what exactly this benefit covers. First one is that CATS program that I just described to you that provides that emergency stabilization for children and youth and their families. The second coordinated specialty program is called ESA, or the Early Assessment and Support Alliance. And the ESA program, there's an ESA program in every county of Oregon, and it's modeled on a national best practice, evidence-based practice for providing a comprehensive array of services to teenagers and young adults experiencing a first break psychosis. So early onset of a major mental illness like schizophrenia or bipolar disorder. There's extensive outreach to the person affected and to their family. People can typically be reluctant to engage in services. They're going through this frightening experience and they don't know what to make of it. But with consistent supportive outreach and then engaging a team with psychiatry, social work, therapy, peer support, occupational therapy, educational support, they're able to achieve really incredible outcomes in working with this population, where the trajectory of that major mental illness is much less severe, and folks are able to go on to college, become gainfully employed, and live much more rewarding and productive lives. So it's intervening really at that critical juncture in the onset of the illness. So that's ESA. Assertive community treatment, or ACT, I like to say, is for people who needed ESA and didn't get it. And so this is for adults with serious mental illness. Often these are folks who may have difficulty maintaining housing, difficulty maintaining employment, frequent users of emergency departments or inpatient units, frequent law enforcement contact. And, 20 years ago, there were very, very few people with commercial insurance who might be in need of services like this. But with the expansions through the Affordable Care Act, it becomes more common for people with commercial insurance to be in need of services like this. And if that's the type of service that you need, you can imagine that an insurance plan that only covers an office visit with a therapist and an office visit with a psychiatrist is not going to do you a whole lot of good if you don't even have the wherewithal to get into that appointment in the first place. So that's sort of community treatment. Next one, intensive outpatient services and supports, or IOSS, is an intensive, as it sounds, outpatient service for children and youth and their families. Again, this is a mobile service. So services provided in the home, services provided in the community or in the school as needed. And then there's a brand new program that just was launched by Oregon Health Authority within the last 6 months, intensive in-home behavioral health treatment, which is very similar to the previous one, IOSS, but it's really an even more intensive model with higher requirements on the providers, higher requirements for involvement of psychiatry, frequency of contact and services. So those 5 programs together constitute the services covered under this new benefit for coordinated specialty programs. Next slide, please. So again, as you probably put together from how I introduced it, this benefit plugs important systemic gaps that we've had in our system of care for people with commercial insurance. Emergency department boarding, particularly for children and youth, was one of the things that led to the development of the CATS programs. That, along with, if you're not going to board, we're going to kick you out of the emergency department without an appropriate aftercare plan. So the CATS program addresses that specific gap. And then more generally, the rigid service models of, once a week therapy or once every other week therapy, or you have to make it into the office when perhaps you're too disorganized or too overwhelmed to make it into the office. It addresses that historical incompatibility between community mental health programs and commercial insurance programs, where they would say, or we would say, you're not serving our members, and they would say, well, it's because you won't pay us for it. So we found a way to bridge that gap. And it also then addresses these issues of, well, is our peer-delivered services a covered service? Is skills training a covered service? Some of these sort of maybe potentially gray areas, because the benefit covers all aspects of the program. It just makes it clear that this entire package of services is covered, and you don't have to piece it out or sort of nickel and dime each individual service, and whether that's being provided by a covered provider or whether it's a billable service or not, because the program itself is contracted and credentialed with Moda Health, and the package of services is a covered service. Next slide, please. So the second new benefit that I'm here to talk to you about, and this actually tags along nicely with the virtual PT program that Dr. Singh was mentioning, is an additional option for people with chronic pain. And it's a program that we colloquially call pain schools. The benefit handbook language calls it disease management program for pain. And that's what it is. It's a disease management program, and it's geared towards people with chronic pain. So in many cases, chronic pain is really a very different phenomenon from acute pain. And the medical treatments that we offer for acute pain are in many cases ineffective in treating chronic pain. And the pain schools were developed, again, by CCOs, and we've been able to build on the work that they have done in that respect in making this covered, to address that gap and really address the psychosocial components of chronic pain. Folks with chronic pain are much more likely to have significant histories of psychosocial trauma, much more likely to have mental health conditions, comorbid mental health conditions, and dealing with the pain in the context that is sensitive to those issues, that's aware of those issues, that's aware of the contributions that mental health, or in some cases substance dependence, can make to the experience of chronic pain, is going to produce different outcomes. Specifically, with chronic pain, one of the things that becomes for many people as debilitating as the pain itself is the fear of that pain. And so these pain schools work specifically to work through the fear that's associated with the pain, that's associated with increased functioning. And by addressing that fear and guiding people towards gradually being able to move more fully, function more fully, and address the fear that goes along with that as they go through that process, achieve more mobility and higher functioning. And it's inspiring to hear people talk about who've been through these pain schools, to talk about how I got my life back. Pain ruled my life, and now I manage my life, and pain's along for the ride. And so it's just a very different experience. Next slide, please. So I mentioned some of the challenges with chronic pain. And again, it's such a different phenomenon from acute pain. And what we found is that routine medical care, in many cases, it doesn't address the issues that keep chronic pain so front and center in people's lives. And oftentimes it's not trauma informed. The pain schools are very explicitly trauma informed, so they address that power differential between provider and patient. You know, I'm not gonna look down at you. I'm not going to just order you what to do. I'm going to work with you collaboratively as an equal partner so that we can discover how you can make progress with this issue in your life. So lack some of that blaming that sometimes, you know, providers with chronic pain, doctors like to solve problems. Chronic pain is not a solvable problem. That can make doctors frustrated. They can end up blaming the patient. You can get into very disempowering loop that way. So this is able to sidestep those kinds of issues with the trauma-informed basis. And so it addresses, again, that issue of chronic pain patients, particularly those with trauma histories, where their experience of care is, they don't listen to me, they don't pay attention to me, they tell me it's all in my head, and they just want me to go away. And helps people really move out of that helpless space into more empowered and more mobile and more highly functioning place. Same thing with the coordinated specialty programs. This new benefit covers the program in full. So they're using alternative therapies. They may be having them do yoga. Is yoga a covered benefit? We don't have to worry about that because this program, which again is overseen and directed by a licensed provider, that serves as part of a covered benefit. It's an integral part of this covered benefit, and so people have access to that piece of the program to help them get through that spot in their lives. And I believe that is the last slide for these two benefits.
Thank you.
Thanks, Dan. And we were asked to
Erica,
provide...
are you doing the vaccine update?
Yes. Actually, Dr. Singh is going to take over for us and provide a quick COVID vaccine update.
So,
Dr. Singh?
As best you can cover it quickly, we'd appreciate it.
Thanks.
Okay, thank you. We'll provide a very brief COVID-19 update then, thank you. Looking at recent hotspots across the country, Oregon, Washington, Texas, Florida, the Midwest, where hotspots over the last couple of months within Oregon, the southern and eastern counties. The good news, of course, today that these are no longer hotspots. Cases are down in almost all of these areas as they are nationally. The global picture is important because, of course, that's where it probably originated, the coronavirus, and where new variants are likely to come from. Some countries globally experiencing their first or second major waves with their health systems overwhelmed, high numbers of cases and deaths. Others, of course, coming off and heading right down. The global picture is also overall in aggregate very good. Numbers are down globally and nationally and locally. Next slide, please. So these are our three options here in the US, and more than enough for the supply that we need. Pfizer, Moderna, Johnson & Johnson. Johnson & Johnson has been particularly valuable in our kind of rural areas because of the single dose nature of it. The biggest issue though now is more demand rather than supply, with that demand leveling off. Next slide, please. Here are the numbers of vaccines given. So Pfizer and Moderna are both very similar in numbers. Johnson & Johnson actually, for our membership here, only used a very small amount there, just a few hundred. The percentage vaccinated with at least a single dose at 46%. Next slide, please.
Yeah, and
Is the 28% including children?
It is, Jeff, yes. And one thing I do want to say about the vaccination rates is we do know that we are not getting all of the claims for the COVID vaccines because people can bill it either to the insurance carrier or to the federal government. We know that we're not getting all those, so that is understated.
Yeah, these numbers are very significantly understated as of today. Obviously, the data comes through, claims, other sources, alert data, some other federal sources, and triangulated and added up, and so we'll see that number come up quite significantly. It's several percent higher, and of course, it's one of the numbers that's altering by the day. At one stage, just a month or two back, it was going up by percent per day. So those numbers are from last week as well. So we know they're already quite a lot higher. Of course, the vaccines are the mainstay to protect us from these variants across the world, all of which have actually reached Oregon, the B117, the UK, South Africa. I won't read through the whole list. You're hearing a lot about these in the media. Unfortunately, you see that bottom row, India. When we looked at this last week, we didn't have confirmed cases in Oregon, but now we do. So there's several of those cases too have reached us here. The vaccines do provide a protection against all of these variants, but to differing percentages of efficacy, and are not as high as the original strains that we saw for some of these variants. Next slide, please. Over time, we've done a lot from our end in terms of reaching out to members, communicating portals, getting the message across that there's no costs to them, expanding telehealth benefits. We did that for all our members across all lines of business, and the physical and behavioral health, eased access to medication, to equipment, and reduced provider administrative burden. Thank you.
Well, thank you very much. We appreciate all the improvements or additions to address the care of our members.
We'd like to take any other questions or discussion about the long list of benefits that we're excited to offer members.
Any questions before we move on to Kaiser? Thank you.
Thank you.
Okay, good afternoon. We are delighted to present an update about what's new at Kaiser Permanente and how we've changed care over the last year plus. I have two amazing experts with me today who've been really instrumental in all the changes in care delivery, improvements in care delivery. I have with me Mary Giswald, who is our Associate Medical Director, overseeing hospital as well as other services. She's a general surgeon by training and profession. I also have Wendy Watson, who is our Care Delivery Chief Operating Officer, with us today. Mary and Wendy have been great partners, representing Kaiser both internally and in the broader community with our coordinated efforts, collaborating with other healthcare systems in terms of both testing and vaccination. So with that, the agenda today with the next slide is we'll just be talking about the impact of the pandemic, where care has gone over the last 15 months, and then our ongoing support for OEB now and into the future. With that, I will turn it over to the next slide to Mary.
Thanks, Keith. And thank you all for having us here today. We're delighted to share some of our experiences over the last 15 months with you all. You know, the pandemic changed all of our lives very quickly. Most of us remember a moment in time when we knew COVID-19 was going to drastically alter our lives. For me, that moment happened on February 28th, 2020 at 4:30 in the afternoon. I received a call from our Chief of Infectious Disease, Dr. Steve Spindell, that one of our patients at Westside Medical Center had tested positive for COVID-19. That person was the first person in the state of Oregon to be diagnosed with COVID-19 and was the first person in the United States to be diagnosed with COVID-19 acquired through community transmission. They also are an OEB member. You know, in the days that follow, we all had to rethink how we approached our work and life as a community. You know, how are we going to run our hospitals, our clinics, schools, health departments, et cetera. And there were a lot of questions about the uncertainty and about safety for healthcare workers, for teachers, other essential workers. And, you know, as we're coming out of the pandemic, we in KP are taking stock of what we've learned during this time so that we hold on to the good things that are making care better for our members and that are making us better healthcare providers. Next slide, please. We certainly had our challenges in KP during the pandemic, but we felt very fortunate to have our integrated structure as the initial, you know, days and weeks unfolded. And so right away, we stood up an incident command center structure with representation of all aspects of our organization. And we were able to approach the rapid cycle changes with things like PPE, testing, social distancing, all across care delivery, you know, all across the ambulatory clinics, the dental clinics, hospitals, because of our unified structure. And it wasn't just the integration of the venues, but it's about the people and their roles. So all of the physicians, the medical staff, the administrators, all work for one program, KP, under an aligned leadership team. So we were really able to move a lot faster than we ever knew we could do. It really allowed us to make quick decisions about how to keep our patients, our members, and employees safe as we learned how to manage with this new disease where there was so much unknown. We also found it very valuable to collaborate with the other healthcare systems to ensure that we were approaching this, you know, in an aligned way for the community. Wendy and I both began meeting regularly with our counterparts at OHSU, Legacy, and Providence so that all 4 large systems could share their best practices around PPE testing and how we were handling elective surgical and procedural care, again, so that we all worked together and shared what we were learning. Next slide, please. You know, to keep people safe, of course, we had to shut down certain venues, but needed to still keep providing care. So we shifted PPE and personnel to our clinics that stayed open, to the emergency departments and the hospitals. We initially consolidated the care of our hospitalized patients with COVID-19 to our Westside Medical Center. And our Westside team became very skilled at the management of critically ill patients of COVID-19 in our isolated COVID unit. We had staff from the closed venues like dental or some of the ambulatory clinics come help in the areas that were more heavily impacted. We had our dental teams and our administrators working things, you know, being greeters, helping with COVID testing, helping do curbside pharmacy delivery. Our nurses from our closed outpatient surgery centers supported our teams in the ICUs and in the recovery rooms. So we really learned how to safely manage people coming into the facilities while, you know, keeping everybody safe through, you know, limiting foot traffic, altering schedules and layouts to accommodate social distancing, and really started doing much more widespread testing. And to ensure that people still had access to ambulatory outpatient care, we increased our virtual offerings by 700%. Next slide, please. Thanks. So I want to talk a little bit about some of the virtual care that we accomplished over the last several months. And specifically, first, let me talk about OEBB, our telehealth trend there. Before pandemic, 29% of the care to OEBB members was done virtually and 71% was face-to-face. During the pandemic, it got as high as 78% virtual and 22% face-to-face. By the end of 2020, we were doing 62% virtual and 38% face-to-face. One interesting statistic, in January of 2020, we did 6 video visits per 1,000 OEBB members. In December of 2020, we did 116 video visits per 1,000 OEB members. So that was, a significant shift in the virtual offerings, and that includes video, phone, e-visits, are all what we, consider our telehealth or our virtual care offerings. One other thing that happened during pandemic that we're very proud of was that we opened the third KP hospital in Oregon, which we call KP at Home. That's our hospital at home program that we opened up under one of the CMS waivers. And to date, we have cared for 563 patients who are hospital level care patients in their own homes. We do this with a combination of in-person care by paramedics, nurses, nurse practitioners, and then the physicians interact with the patients via video. And the feedback we're receiving so far from our patients who've had this experience has been really positive. They feel supported, they feel very connected to their care teams, and yet they're comfortable in their own homes. And we know from published data around hospital at home programs that there's other real quality values here where people get less debilitated being hospitalized at home versus in a true hospital. So with the right program and workflows and the right patient selection, this is something that really is scalable, and that so far our patients are really like, and our physicians feel really good about this too. In OB, we are really learned a lot during pandemic about how we can use virtual care. And early in the pandemic, our OB teams changed the way they deliver care by offering, they were alternating virtual and in-person visits for our expectant mothers. And again, it allowed us to maintain social distancing in the OB clinics, which can be very, very busy. Many expectant mothers really appreciated the convenience. So now, as a next iteration, we're doing a pilot for clinically appropriate, lower risk mothers who want a more virtual experience. We're providing them monitoring equipment so that they can check on their baby's heart rate at home and regularly interact with their care team virtually. So it allows them to have more flexibility with fewer in-person visits, yet still be able to monitor their progress and stay connected to their doctors. In PT, we also had some transformation around virtual care. Prior to the pandemic, we were doing about 10% virtual PT. And during the pandemic, we actually very quickly went to 95% of our visits as video. And I think we were really unique in this space because many other PT programs, clinics had no access to virtual care and they had to close. But we were able to continue offering PT to our patients, both in person and in group visits through our video platforms. Now that's leveled out a little bit, and so we're at about 50% virtual care, but we learned a lot, and we found many conditions that are very amenable, and many patients that really, really want the virtual experience as opposed to coming in face-to-face. Okay, Dr. Bachman, I think I'm turning it back over to you.
Great. Next slide. Just a note on mental health and behavioral health, and we could really talk more about this. This is the long shadow of the infectious pandemic of COVID, that it has affected the behavioral health status of our population, both inside and outside OEB. We see the reports from the Oregon Health Authority and the Washington Health Authority about increased hospitalizations, increased ER visits, increased suicide attempts, severe substance abuse. All that's really come about in the last year, related at some level to COVID. These are real statistics. These are real health problems. This is really part of a public health emergency related to behavioral health. Even prior to COVID, the need for behavioral health services was increasing, and we were meeting that demand, and it's continued to be a challenge to do that during COVID. Having the virtual technology available has really actually worked out well in behavioral health. It's provided more flexibility in terms of geographic access to members. And with the video linkage, it's both acceptable to members and really provides great eye contact and other information between members and clinicians. And I would anticipate going forward that will continue to be a valid access for getting therapy. One innovation, and really at Kaiser Permanente, of the highest level of primary care behavioral health integration, really in our market, or really in the country. We've embedded behavioral health consultants, which are generalist therapists who have expertise both in addiction medicine, lifestyle behavior change, and mental health therapy, and really embed that in primary care for warm handoffs, whether someone's in the office or doing a phone or video visit. Those folks are able to get a better story, get some more information, have access and knowledge of the other aspects of treatment within the healthcare system, whether that's and as well as lifestyle coaching, which is really quite successful. I mean, we know the evidence is that exercise is as good of a antidepressant for people with mild to moderate depression as a prescription for a medication like sertraline or fluoxetine. The behavioral health consultant can refer for more intensive treatment, like our intensive outpatient therapy. We've enhanced and expanded that program, or they could refer to our inpatient residential program at our Brookside, or they may refer if someone needs longer term therapy, they can refer for that as well, or they can start some therapy themselves. We have seen as one of the access concerns or challenges during COVID is the more number of treatment visits that are medically appropriate or being authorized as needed by a therapist. We are pleased this week, just this week, to announce that we have a partnership with Ginger, which is a national virtual therapy model that hires clinicians around the country and connect through a virtual program to members who need that therapy. So all this stuff is all the package of all the different services that we do. One other innovation that we've really leaned on during COVID, it started before COVID, was both self-service and referred apps for both mindfulness and cognitive behavioral therapy. We use the Calm app, which is one of the leading mindfulness apps that can be used for meditation, for anxiety management, for sleep management, and just general improvement. And My Strength is a digital therapeutics program through Livongo that provides cognitive behavioral therapy. So it's really this whole package of things we're able to really use and integrate virtual programs along with face-to-face visits as needed to meet the increased behavioral demands in both addiction medicine and in behavioral medicine or mental health medicine throughout this pandemic. Next slide. So outside the, I think outside the clinical arena, we've been supporting OEB in many different ways. We developed a popular nationally, Kaiser Permanente nationally, a return to the classroom playbook to help educators educate them around some of the issues around COVID and the challenges of being an educator or being a student in this environment. We provide a virtual webinar, frequent communications, hosting office hours and virtual open enrollment for OEB during the pandemic. Next slide. And we'll continue to be supportive with wellness newsletters. We're very excited to really be in our second grant process for a wellness-based grants, which we think is great timing as educators are thinking about returning back to work in the fall, and it's a great time to kind of build out those spaces, consider with school wellness committees what's most effective of providing a safe space and a sanctuary space and a restful space for educators in their school environments. And we'll continue to sponsor flu shot clinics throughout the OEB service area. Finally, the Thriving Schools Rise initiative is a online educational program that can help teachers and districts and staff understand stress and help mitigate that to help provide more resiliency and positive learning environments, understanding that human connection and empathy is really the key for resiliency and really what is needed to kind of move forward with today's challenges. I'll turn this over to Wendy for the next slide to shift back to information around our vaccine distribution program.
Great, thanks, Keith. So for the last several months, vaccines have been a very heavy focus for us. If you could go back one slide. So, from the moment the very first vaccine was approved and arrived at our Airport Way Distribution Center, we kicked into high gear and began vaccinating, starting with our employees. And what we quickly recognized with this particular vaccine is that it would go way too slow if each of the health systems tried to do this all independently. So we quickly identified the opportunity to sync up efforts and not focus just on vaccinating our own members, but instead partner up with our health system partners in the community and look at how do we join forces and vaccinate the community and get to herd immunity as quickly as possible. So Mary mentioned the partnerships that we created with Legacy, Providence, and OHSU as we were going through the pandemic. And so we all quickly came together, came up with a plan to do a mass vaccination site at the Oregon Convention Center and implemented that very early in the process, recognizing that that would be the way for us to most rapidly vaccinate the community. So that All for Oregon effort, in the time we've been open, we have administered over 530,000 shots so far at that location, which has been a significant contribution to the Tri-County in particular vaccination rates. The other thing I want to call out, I would say one of the greatest highlights of that All for Oregon experience has been our partnership with school leadership and the joint effort we had to ensure that we were going to get our educators vaccinated as quickly as possible as soon as Governor Brown prioritized them. And that was just a great partnership where we came together on a very regular basis and partnered together to figure out the fastest, most effective, efficient way to get through all of the educators and get them vaccinated. So I want to call that out as a great success. And so for the Kaiser Permanente OEB vaccination data, I'm very happy to report that at the 16 plus age group, we're at 71.9% vaccinated at this point. And for the 12 plus, we're at 67.9% vaccinated. And those vaccination rates are as of May 19th, so they're even higher than that. That was just the latest data that we were able to pull. And our data comes from the alert system where the vaccine is administered. It's not relying upon claims data, so it's pretty accurate and timely. This also means this is a vaccination for not just OEB employees, but dependents and family members as well. Next slide, please. So health equity, a very critical priority for Kaiser Permanente, and really became front and center in our pandemic and vaccination related efforts. We knew we were going to need to do more in this space to really ensure that we were getting to all populations and everyone, no matter where they resided, no matter what their circumstances were. So one of the things we did was some extra outreach during the pandemic. We would do text and email campaigns in multiple languages, relied upon social media influencers, and then did public service announcements. So we tried to partner as broadly as we could to get word out about the importance of vaccinations, about virtual care capabilities. And then in the vaccination space, in addition to our All for Oregon Vaccination Center at the Convention Center, we've been partnering with community-based organizations to do targeted vaccine clinics. So we've done Latinx, Pacific Islander, BIPOC, limited English speakers, and homeless focused vaccine clinics. We've also just started up a partnership with Medical Teams International to do mobile vaccine clinics out in places that are harder to reach. And then we've been providing grants to CBOs to be able to address vaccine hesitancy and to support them in doing vaccine clinics out in communities that are closer to people if they can't come into Convention Center or to Kaiser Permanente medical offices. Just in addition to all of that, health equity is a priority for us in our ongoing care delivery. We really worked to make our interpretation services more robust and especially virtual interpretive services as our care delivery shifted virtual. We have several Latino modules, and we're in the early planning stages for a Black Center of Excellence that we plan to implement at our interstate medical office. And then finally, in our clinical quality work, we're looking at racial disparities in many of our clinical quality metrics and focusing on that as well. One example being in the area of diabetes care. Next slide, please. So looking ahead, it does feel now like we're starting to come out of the pandemic, which is great. It's fantastic seeing our educators back in school and our kids back in the schools as well. We're going to continue the focus on vaccinations. We are not to herd immunity yet, so this is still a very big priority for us, especially as the mass vaccination centers start to close down and we see less demand there. Now it's more about this targeted outreach and really addressing vaccine hesitancy. So that's been our focus area in recent days and weeks. We also plan to continue to build on our experiences. While the pandemic brought many challenges to us, we've also learned and grown and really demonstrated that we can do things differently. Virtual care, certainly, our focus on health equity, and then advancing social health strategies were things that really went in hyperdrive during the pandemic, and now we can leverage them even moving out of the pandemic further. OEB has been just such a fantastic group for us to work with. We know that as we provide care and support for you, you are able to provide support for our community. So continuing to partner with you is definitely a support.
Oh my God.
And making sure that we're addressing the health, wellness, and social needs for our OEB members. And I think that's it. I do have a few, I heard that you wanted a little COVID update, so I have our latest COVID stats. If you would like me to throw that in here as well, I'll just end on that note and then we can open it up for questions. So we are starting to see improvement in the COVID demand. So we currently have 24 COVID patients at Sunnyside and Westside. So that's been coming down. And then we have 18 outside of Kaiser Permanente hospitals. The really great news is our positivity rate is dropping. So we are now at a 4.6% positivity rate. Just 1 month ago, we were above 10%. Our weekly average cases are dropping. We're down 39% from the prior week. And we're still actively working on surgical backlog and deferred care that occurred during the pandemic. I will say our hospitals are very full, as is the case across the community. We are starting to see demand really pick back up again for, and this isn't COVID, but this is just demand overall. So there is, I think we're starting to see people comfortable coming back in to receive care, and then also just, most likely the impact from some deferred care that happened during the pandemic. So I think I'll end with that and open it up for questions.
It helps if I take it off mute. I don't see any hands. Thank you very much for your presentation and update. We'll move on to the consultant RFP update. Brian Olson.
Jeff?
Yes.
It's been 2 hours and 20 minutes since we've started up again. Is it possible for us to have like maybe about a 3-minute break?
Of course.
Thank you.
And, this is Brian. Claudia, do we have you on to present?
Brian, we're going to take a 3-minute break.
Okay, I'm just making sure Claudia's on to present. Claudia, do we got you on?
Go ahead, Tom.
Well, I will need the 3 minutes to brush up really quick.
Okay, good. Back at 3:23.
Okay, the message is I'm not muted.
We can hear you, Claudia. You're unmuted now.
Okay. Hi.
We're picking back up in just a minute or two.
Okay, that's fine. I'm ready. Let me get back into my.
Then I'll stop. I was doing a quick crash course refresher, so I'll pause.
Okay, I'll get back to the presentation. Sorry. I just won't touch anything.
So you're good to go. I think Jeff will prompt us to pick back up in a couple. So I'm going to go on mute.
Okay.
Hey, Claudia, are you scrolling?
Yeah.
Okay. It's pretty loud. I was just making sure I knew what that was.
Okay, let me go down to the presentation, even though I can do it. Well, at least you can hear me now.
Yep, loud and clear.
Okay, thank you.
Okay.
Hey, Jeff, my neighbor's pool just exploded.
There what?
I just heard a big pop and I looked out, there's water all over my neighbor's pool let go.
Oh,
That's
must be
exciting.
a blow.
20,000 gallons of water, but hey, no problem.
Bonnie, hopefully are you uphill?
I am.
Wow.
I thought, what was that noise? I got up and looked up and oh my goodness.
Well, the plants will like it.
Yeah.
Okay, Tom, we got you back.
I am back. Thank you.
Great. All right. So Brian and Claudia.
Okay, can you hear me now, everyone?
Yes. Yes.
Okay. So this is with regard to the consultant RFP. We came and did an informational only presentation last month, listened to questions and concerns from both boards, and are prepared to come to you today and request your action to approve the RFP as written in this document. If you like, I can go through and highlight the updates that we've made based on your feedback, or in the essence of time, we can just move to the motion and I'll defer to the board for that.
Okay, board members, what's your preference?
This is JJ. I move to approve.
Ah.
This is Reed, I second.
Okay. It's been moved and seconded. Do we have any discussion or questions? There being loud silence, we can move on to a vote. This one, I think we need a roll call on. So let me just grab my thing. Okay. Robert.
Aye.
Bill.
Aye.
Bonnie.
Aye.
Susan. Susan Miller. JJ.
Aye.
Reed.
Aye.
Bob.
Aye.
Tom.
Yes.
Motion carries.
Thank you.
Well, thank you guys.
Thank
You're
you.
welcome.
And the last thing, well, second to last thing on our agenda is the CO update. Tom?
Yeah. Rose, do you have that summary piece? We ended up starting with our annual dental performance report, and we compared the October 2019 through September 2020, which included the major hit of the COVID pandemic, with the previous year. And what Willis Towers Watson gave us was an executive summary. And I thought this pretty much identified so much of what they talked about that it was just easier for me to have you be able to look at it directly. There were some small changes in what was offered in the plan in the benefit department. In terms of membership, there were no significant changes over the 2 years. Where it says combined cost trend, this is the one that's the most profound, in that the total cost dropped 15%. It went from about 80 million down to the high 60 million range. And that was as compared to the previous 5 years, there were an average of about 2% per year. So no question, the impact of the COVID pandemic was a significant drop in dental costs, and utilization was the cause of that. So you can see with next page. And this is a very busy slide. It shows membership that we talked about. Here's the total spend, 77.4 million down to 65.7 million. The important under use of services, you'll see prior, which was the 18-19 plan year, current is the 19-20 plan year, and you can see for each of the our dental providers a drop in that from the prior year to the current year, and in the range of 15-20%. The first bucket on the left, or the first three, are prevention. Then you have basic, which includes things like restorations, filling cavities, things like that. And then major is where there's oral surgery and endodontic work. Okay, next page. Or is that it? That might be no, that's right. And then this next one, I wanted to bring out the top left. You'll see cost share per member, and the yellow is Delta Dental. The middle one is the Kaiser Permanente plan, and then Willamette Dental Group is the blue. And you can see not much change in terms of the amount of cost share. 20% cost share by members for the Delta plans, 6% for the Kaiser plans, 15% for the Willamette Dental plan. More detail on the bottom, you'll see more detail in regards to prevention. What's interesting here is that instead of looking just at a 12-month window, they expanded it to an 18 and a 24. And when you did that, in general, you saw an increase in the number of people who had gotten these services. And I think that's all I'm going to have you show at this point for that, Rose. Thank you very much. We then had each of the dental plans talk about specific utilization, and it was a common finding for all of them that they're all back to pre-COVID utilization numbers. These measures were either by the end of December 2020 or into the first month or two of 2021. And all of them had a gap or everything dropped out almost completely except for oral surgeries or essentially dental emergencies from the middle of March until July, August. What you'll see is a more rapid return to normal with the Delta plans. The Willamette Dental Group and the Kaiser Permanente Dental Program took somewhat longer, probably 2 to 3 months longer, for them to get back to their baseline numbers. So at this point, and so that's utilization was kind of as we predicted. They did not see a rebound where the utilization bumped significantly above the previous pre-COVID utilization. So the question is, was there a demand that, unmet demand that was now going through the system? It has not been seen. And the question is will it be seen at some point in the future, or have we basically, gotten to where we're going to be? In the last presentation by Kaiser, they talked about hospitals being very full and maybe dealing with some unmet demand, pent-up demand. At least in the dental programs, all of them thought that was not a major issue for them. We had, if you look at prevention, and particularly dealing with members who are part of health dental plans who have never been seen before, we had noticed that with both the Willamette Dental and the Kaiser plans, there were what we thought were significant numbers when we've talked about it in the past. And both Kaiser and Willamette have worked on programs to improve their outreach to these people. Kaiser, for example, sent 11,000 letters to people who hadn't been seen in the last 12 months. 15% of these people had appointments scheduled. The Willamette Dental Group had an outreach for new patients, 3,700 postcards sent, a second mail in January, and a second outreach in March going into April, that time sometimes using email and voicemail. And they've had 17% of those people have been appointed. One of the things that helped with this was they had waived their $20 office copay to improve that. So good news all around. So that's the dental update. Plans that we have with dental, the 3 dental plans have come together and have an idea where where they have agreement around some quality metrics that we can follow. We'll meet with them in September about that. The next subject that we had was we wanted to look at the impact of COVID on prevention and early detection. And essentially, both MODA and Kaiser Permanente have seen a normalization that occurred by the fall and going into the winter. Kaiser ended up showing it had OEBB has a consistently higher quality scores than Kaiser's book of business. All of the numbers are coming. There was the lowest drop was by the summertime, and improvement by December 2020. And as say utilization, which is the actual number of procedures or tests that are being done in a given month, that is all back to normal. Same thing with MODA, with almost all of their utilization showing back to pre-COVID levels by September and stable since then without a rebound. The last two subjects are the WW for diabetes and the Healthy Team, Healthy You that we've already discussed. So any additional clarification or comments from our other committee members?
I think you got it. Thank you.
No, well done.
And I wanted to also to highlight Bill Gropp for his wonderful participation in CIAL. He's kept us honest. He gives us a not a contrarian, but a very rich view of what it's like from trying to organize care for in a financially appropriate way. But Bill, you've been there. You started there as a volunteer. You weren't even on the committee and showed up every Tuesday morning. I was so impressed by that. So you'll be missed.
Thanks.
You're here.
Appreciate the comments.
Okay, is there any other business? Rose, how long is the sign up for public comment?
It must be really long, Jeff.
She's still counting.
I'm sorry. I'm sorry. I have it muted in two places. There's 14 pages of public comment. No, there's no public comment.
Okay. Perfect ending. Good. Thank you all. Have a great summer. Look forward to seeing most of you back in September. The meeting is adjourned.
Jeff?
Yes.
Thank you for your